and and the neurological conditions. Uh, so the program starts with a review, an overview of the neurological programs or diseases associated with COVID-19. But each of the speaker will be talking about their own subspecialties regarding their experiences, aside from the updates. So we have headaches, we have seizures and epilepsy, we have dementia. We have an overview of neuroimaging. At the end of the day, we're going to talk about vaccines and neurological conditions, and that's going to be an ethics talk. So I'm going to start the discussion by talking about neurological conditions in COVID-19. So this is an overview and a review. It's not as exhaustive or as deep as we can, but at least you'll have a glimpse of what happens. This slide just shows you the different conditions that we've been dealt with throughout our human history. I'm not sure you're familiar with this slide, but the bottom one, I'm pointing with the arrow, is where COVID stands. As you can see, the number of folks who died from other conditions, even HIV, as recently as the HIV epidemic that we all went through, or still going through. If you look at all these conditions, and based on the population that are involved, COVID-19 is way in the bottom in terms of percentage of deaths. There's about 4.8 million deaths, as opposed to 30 million with AIDS, Spanish flu, and so forth. Despite that, we know the impact it has on us, both medically, socially, and psychologically. As of at least last night, the World Health Organization, WHO, has noted that there are about 251 million confirmed cases of COVID-19 in the world, and there are already 5 million deaths, over 5 million deaths. In the United States, as of last night, there were over 46 million confirmed cases and about 755,000 deaths. We're almost reaching 20% of the death rate of the world. We know that COVID-19 affects different organ systems. It's really a multisystemic condition. Our focus today will be on neurology. Of course, the early symptoms of COVID-19 were very nonspecific. You could see them in any viral illness in general. You have myalgia, you have the headaches, you have the fever, you have the fatigue, you have the coughing. What's peculiar was there's a high incidence of smell disturbances, including anosmia and ageusia. Anosmia refers to lack of smell, and there are different categories, like hyposmia, which is decreased, or parasomnia, which is distorted smell. Ageusia refers to the sense of smell. Up to 60% of folks. If you notice the list of early symptoms, half of them are already neurological, but we thought they were non-specific since we see them in a lot of viral conditions. As neurologists, we're always seeing folks with smell disturbances and muscle aches, and we always assume there may be an inflammatory condition that started it. In fact, the two most common reasons for that would be, for anosmia, would be trauma and perhaps post-infectious process. So the ENT doctor just sends us patients, we send them patients to clear them. The realization of neurological issues started to come really early part of 2020. In February, from Wuhan, China, there was a case series study about 214 patients that showed the neurological manifestation of hospitalized patients in COVID-19. That story started the interest of many people. Subsequently, by March, there were case reports, and subsequently more case reports of meningitis and encephalitis. By April, the reports of Guillain-Barré and speculations about the relationship to the SARS virus. By May, stroke and the pathogenesis were all being discussed. And since then, there have been systemic reviews of different neurological manifestations of COVID-19. Now, the latest article that I can find was published, not even published, it's preprint, published online, but not yet printed, in Neurology, just about less than a month ago, approximately a month ago, by Misra. And the title is The Frequency of Neurological Manifestations in COVID-19. It was a systemic review and meta-analysis. They reviewed about 2,455 citations and included 350 studies. And they divided the symptoms, the neurological manifestations into symptoms and diagnosis. There were 24 neurological symptoms and 17 neurological diagnoses. Now, there are always advantages and disadvantages to meta-analysis. Not my favorite way of looking at things. There's an inherent bias because you're not including many articles and many patients and manifestations. But because of the lack of science, this is the best that we could do. And I thought it was a good meta-analysis. And this is just a list of the neurological symptoms. And their categorization, for example, includes fatigue and myalgia, and they put it together as myalgia or fatigue. And that's the difficulty of meta-analysis. You get the articles, review them, and you're a slave of how they define the symptoms. In this particular list, what we saw was fever, fatigue, myalgia, headaches, dizziness, smell impairments are the most common. The other symptoms are diminished. As you can notice, their agitation is high, particularly in the older age group. In terms of the neurological diagnosis, encephalopathy was high, neuropsychiatric disorders were high, and stroke was very high. The pooled data was very high in the stroke, even if it says 2%. And if you notice, Guillain-Barré syndrome, radiculitis were not as high as a group. What were the trends that they showed, aside from knowing all those symptoms that can occur? As you know, notice it's a variety of symptoms that somebody with COVID-19 can have. And if you look at the whole picture, if you have a viral syndrome, you go to the hospital, you can have a lot of the symptoms. We've seen them, except that the magnitude of manifestation is just too much. In terms of severity, most folks who have severe COVID-19 would show encephalopathy or disorders of consciousness and muscle involvement. The more severe cases would present with smell and taste disturbances. In the hospital patient, most of them have fatigue or myalgia, and the non-hospital patients just had smell or taste disturbances or headaches. In terms of age, the older folks had more confusion and delirium, while the younger ones were more tired. One of the most significant aspects of the study was that it showed that almost a third of the patients, if they have one neurological symptom or diagnosis, may die. That's very high. So it's a bad prognosticator. In fact, if you were over 60 years of age and you had any of the neurological conditions, your odds ratio of dying is almost double, about 1.8. That's pretty high too. We have speculated on how COVID-19 affects the nervous system. And we all thought, hey, there's direct invasion for sure. But we also know that there's systemic dysfunction that affects the brain. Anybody who's hospitalized would have some sort of neurological manifestation sometime if they're there long enough, especially if they're intubated, especially if their respiratory status is affected. And we speculated about immune dysfunction. In terms of direct brain involvement, there are many possibilities of how the virus can enter the brain. The virus spike protein attaches to the ACE2 complex. angiotensin converting enzyme 2, which is present in many cells and organ systems, particularly the nervous system. So we're all worried that it may do so, even in the blood vessels themselves. So there's a proposal that may be due to endothelial invasion. Of course, we lose the sense of smell, and we know that most respiratory organisms pass through the nasal passages. And olfactory route was also proposed. And from the lungs, it was proposed that there's a transneural uptake of the virus. However, if you look at the pathologies, the specimens, direct vein involvement has not really been proven. How about systemic dysfunction? As I mentioned, if you go to the hospital, you're intubated, and you have a lot of risk factors, you're going to have metabolic abnormalities. Systemic conditions will affect the brain. So you have metabolic derangement, you have organ failure, you have hypoxia. Of course, you're placed on many medications, which also can affect the nervous system. Indeed, when you look at the pathological specimens, it's very nonspecific. The neuronal patterns are very nonspecific. Most of them may be due to acute hypoxic damage. How about immune dysfunction? We always, as neurologists, are sent patients with unusual neurological conditions. Either they're weak on one side, they have numbness on one side, they have a headache. And if you look at the history, there seems to be an inflammatory condition before that. Either they had diarrhea or they had a sniffle, which they just neglected to think about. And we know that there is an inflammatory component to that. It's either infectious or autoimmune, as we always say. With COVID-19, there's elevated markers for inflammation. You have tumor necrosis factor, you have interleukin-6, and it is said that the pro-inflammatory state may lead to stroke because of destruction. The coagulopathy that occurs may lead to vascular insults. Again, the pathology shows significant inflammatory activity. There are microglial nodules, there's neuronophagia, but the brain tissue does not show direct invasion, again, of the virus. This cartoon just shows you the mechanisms that I just talked about. And as I said, the direct viral invasion has not been proven, but you can have the cytokine production, and of course, coagulopathy that may lead to the neurological manifestations. Now, when we talk about neurological symptoms and signs and diagnosis, we sometimes can look at them in terms of time of occurrence. Either they're acute or post-acute. Post-acute just means that the initial insult occurred and there's a reaction somewhere that may have wreaked havoc on the organ system. In neurology also, we want to look at the localization. We always say, ask where the lesion is and I'll tell you what it is. It gives us a way to diagnose, look at the differential diagnose, and sometimes treat and prognosticate. And just as a overview, the acute manifestations in hospitalized patients can be seen about 13 and 14%. In the article I just mentioned that was published that looked at the frequency, almost a third of hospitalized patients actually have a neurological manifestation. In post-acute, it is said that up to 25% of survivors would have persistent neurological conditions. In some papers, it even goes up to 2/3. But in terms of the timeline, that's what dictates the number. A lot of people do recover. And in our practice, we've seen a lot of folks after COVID with many, many neurological symptoms. We follow over time. These are not the heavy-duty long haulers, as we call them, but they have indeed isolated neurological conditions. Majority do still get better. Time seems to heal. The body seems to repair itself. You just have to be healthy in many other aspects. Now, this is just a categorization in terms of timeline of the different symptoms of occurrence. Perhaps for discussion, it's easier to look at it from a localization standpoint. In the central nervous system, I'm including anosmia. You know, cranial number one is more peripheral, but the olfactory bulb is more central. There's encephalopathy, there's meningoencephalitis, there's stroke, there's acute necrotizing hemorrhagic encephalopathy and acute disseminated encephalomyelitis. We have involvement of the spinal cord. These are just direct insults to the brain and the spinal cord. On the other hand, the peripheral nervous system, you have inflammation of the muscles, you have Guillain-Barré syndrome, you have neuropathies. And of course, it's hard to categorize long COVID or post-acute COVID. And there's a condition in children called multisystem inflammatory or inflammation condition, MIS, which is associated with the incidence of or spike of COVID-19. That's also multi-organ. And it can affect different parts of the nervous system, central or peripheral. Let's talk about the sprinkling of these different symptoms, anosmia and dysgeusia. In one series, it goes up to 80% of patients having dysgeusia or anosmia. Usually, it's hard to say whether you're having a problem with the sense of smell or taste because they're almost like interrelated. The aroma of coffee is not necessarily the taste of coffee. In one meta-analysis, up to half of the patients have smell disorder. Usually, it's in the initial phase, even if you're not congested. Usually lasts for about 8 days. But if you ask them intently, it can last for about a month subjectively. And if you do a smell test and really objectively measure the sense of smell, it can last for 4 months and up to 8 months. And I've had patients who still have distorted smell or lack of smell or no smell up to this time, about 8 months, 9 months. I think the longest I'm still following one about 10 months so far. It's very disabling not to be able to smell things. It's actually a disability. We take it for granted until we lose it, just like anything else. In terms of imaging, what are found are usually transient abnormalities in the olfactory cleft or nasal cavities in the olfactory bulb. Just as a review, as you can see, this is the olfactory bulb, the yellow one, and these are the olfactory nerves, cranial nerve number 1. Cranial number 1 is the only part of the nervous system that I know of, at least, that seems to repair itself. It can be destroyed, it can cycle, and then it can repair itself. It can regenerate. So if you have a destruction of that area, wait a while, it will repair itself unless other structures are involved. But as you can see, all of this can be congested and this smell function will be disturbed. This is just a cartoon to let you know that this is the olfactory cells and this is the dendrites that go to the cilia where the odors are coming in, and then it connects with the mitral cells that goes to the olfactory bulb that goes to the olfactory tract. Any of those can be affected. And in this picture, this is a 27-year-old with the SARS positive test. And the top one is actually the MRI. A is within a week, and B is after approximately 3 weeks. The reconstruction shows you the bottom two. On the left side, you see this areas, that's olfactory bulb. And this is the olfactory cleft. This is the ethmoid sinus. This is the orbit. As you can see, the paranasal areas is very congested. This is the first week. On the third week, the same olfactory bulb becomes smaller. So the edema goes away. So those are common things that you see when you do the MRI. If you look at the pathology or the specimens, there's an inflammatory infiltrate. There may be axonal injury of the tracts, but again, there was no direct invasion of the virus that can be seen, but this is a small sample. What about encephalopathy? Well, there are two ways that patients come. One is either they're delirious and agitated, or they're somnolent and they have depressed consciousness. It could be either or. And some even come with seizures. And when you examine them, they have a lot of long tract signs, cortical spinal tract findings. In an ICU cohort, up to half the folks had encephalopathy. They were usually older, male, and the time to hospitalization is usually short. And the risk factors include neurological disease, cancer, chronic renal disease, diabetes, heart failure, hypertension, smoking, all the risk factors for COVID-19 also. There are risk factors for stroke to some degree. In an ER cohort, emergency room cohort, about the third presented with encephalopathy. Usually they're older. What's interesting is up to a third of them did not have the typical COVID-19 symptoms like fever and dyspnea. We always are called in practice with our patients having cognitive dysfunction. They're delirious, they're agitated, they're sleepy. There must be something neurological, and they're right. The question is it direct or indirect? And our usual answer is look for a medical condition. Let's get a medical clearance. By and large, these patients, particularly the elderly or older age group, would have an unrecognized urinary tract infection or even a respiratory infection. They do not have the usual manifestation. The risk factors are the same. They're older with visual impairment, history of stroke or Parkinson's disease, or prior use of psychoactive medication. They're more prone to have encephalopathy. If you look at the imaging of these patients, they're usually negative. Occasionally, imaging would show symmetric bilateral high signal intensities. Occasionally, you can have microhemorrhages in the corpus callosum or adjacent cortical regions. The spinal fluid testing usually is negative also. There's not even an increase in white blood cells, and SARS is not detected in the spinal fluid. The EEG shows non-specific findings. They're usually just slowing of brain waves. This is an MRI of 60-year-old who SARS with encephalopathy. As you notice, there's significant amount of white matter changes in the subcortical regions. Those are usually non-specific findings, maybe due to post-hypoxic leukoencephalopathy. Now, what's the mechanism? Critical illness. If you're ill for whatever reason, you can have encephalopathy. As mentioned, metabolic dysfunction, hypoxemia, maybe there. There's always speculation about direct nervous system involvement, but we've never been able to prove it completely. The prognosis is usually poor. Patients with encephalopathy stay longer. They have worse functional outcome. About a third would have subjective impairment. There's a higher mortality, 22% versus 3%. Again, as we mentioned, if you were over 60 and you had one neurological condition, including encephalopathy, the odds of dying is about almost twice. What about stroke? The usual manifestations of stroke are either ischemic or hemorrhagic. And we, of course, have the cerebral venous thrombosis that we see that's the high there because of the side effects of or adverse reactions from vaccines. Usually, the milder the COVID infection, the less the chance of having a stroke. And the more severe, the higher the chance of having a stroke. The risk factors are the typical vascular risk factors: high blood pressure, sugar, cholesterol, smoking. But we also have myocarditis, inflammation. We also have acute respiratory distress. We also have multi-organ failure. The pathophysiology is possibly many mechanisms. One is coagulopathy. Patients with SARS have elevated D-dimer. They're positive for antiphospholipid antibodies. It could be cardiogenic. Many patients have myocarditis, have arrhythmias, heart failure, myocardial infarction. I had one patient who had recurrent atrial fibrillation after COVID. The pro-inflammatory state also pushes one to have coagulopathies. In the cardiovascular health study, it said that the risk of ischemic stroke increased after hospitalization for infection within 30 days. So if you have concomitant infection, there's a higher risk of having ischemic stroke. What's the prognosis? If you have COVID-19 and you had a stroke, you have a higher chance of having disability. The National Institute of Health stroke scale in a hospital series was higher in patients with COVID-19 and stroke. In a pooled data analysis, it was still higher. Now, this is a 58-year-old patient with ischemic stroke, positive SARS, and this is the cerebellar area. This is an MRI showing hyperintensity, and this is the CAT scan. I think this patient passed. This area in the posterior fossa is very, very tight space. You have swelling in that area. There's nowhere for the brain to go but down. This is a 24-year-old with inflammation, the blood vessel vasculitis. On the left side upper part, you see these arrows. I don't know if you can see that. There's beating of the lenticular striate vessels, suggesting some pathology. And this is a CTA. This is the MRA. You can see it better here. And on the right side, you see areas of the basal ganglia lighting up. What's interesting is this patient was given steroids and prednisone. You look at the bottom, the blood vessels are clearer and the lesions in the basal ganglia are less. So this patient recovered. The proposed mechanism is vasculitis. If left unattended, those blood vessels will just close up and there's no blood flow to that part of the brain. This is a 38-year-old with an intracerebral hemorrhage. I mentioned this because this patient at SARS, I include this patient at SARS and was going through ECMO. This patient could not be helped by the standard respiratory intubation and so forth. There's a high risk of hemorrhages in patients because they're infused with heparin while undergoing ECMO. Viral meningoencephalitis is a rare occurrence. They, in one case, report the patient had seizures, had encephalopathy, imaging of temporal lobe showed lesions. There was increased cells in the spinal fluid. Interestingly, the nasal swab was negative for SARS, but the spinal fluid was. Autopsy studies, however, still do not show definite suggestion that the brain is involved. In a series of 43 patients, half had SARS RNA and proteins in the brain, but it's a low copy, so it was not as high, it's not as definitive. And none of them were associated with significant pathology in the neurons, including astrogliosis or ischemic inflammatory lesions. So it's still not proven as a direct invasion. This is a 24-year-old patient with meningoencephalitis. If you notice here on A, that's the area of the lateral ventricle lighting up. And this is a look at the medial temporal lobe region, a coronal shot of it with some contrast. And this is just to show the significant paranasal congestion that this patient has. There's a rare condition called acute necrotizing hemorrhagic encephalopathy. It's a rare condition. These patients come with encephalopathy. This condition, by the way, can be seen in many viral conditions, including influenza. So it's not unique, except the sheer number. Usually you find bilateral hemorrhagic. There's blood in the thalamus, the brain, and the brainstem. It's said that the mechanism is more cytokine release. The prognosis is poor, but some patients respond to IV, IG, and plasmapheresis, but not steroids. This is a 58-year-old with acute necrotizing hemorrhagic encephalopathy. If you notice, in the upper part, you have lesions in the medial temporal area and in the thalamus. Look at the thalamic region. And if you go down here, you can see some suggestions of hemorrhages in here. And if you do contrast studies, they're ring-like lesions. Usually this is devastating. What about acute disseminated encephalomyelitis? In this case, there's no blood. These patients also come with encephalopathy with multifocal deficits. A lot of these conditions affect the brain. So neurologically, when you see them, they can only have so many manifestations. It's when you look at the imaging and do other testing that you can sometimes differentiate. The MRI usually shows T2 and flare abnormalities in the deep white matter and gray white matter interfaces. Usually there's no blood in them. What's interesting is the lesions may not enhance. The pathology is usually perivenous sleeve of demyelination. The demyelination is the lining of the nerves, and it's usually around the blood drainages, and the blood vessels are congested. Again, the prognosis is poor, but they may sometimes respond to high-dose steroids as opposed to the acute necrotizing hemorrhagic type. So this is a 49-year-old patient with acute disseminated encephalomyelitis. Look at the multiple lesions in the subcortical regions, different parts of the brain, different MRI sequences. This is the brainstem being involved. It's called encephalomyelitis because sometimes the spinal cord is also involved. What's interesting is look at the bottom imaging. Those are contrast studies. None of them enhanced. Usually they do. My worst patient with acute disseminated encephalomyelitis, we did not know what caused it, but there was an inflammatory condition. His brain and spinal cord were full of these lesions. The good thing is he survived. He's only on baclofen, a little bit of Valium because of spasticity, but that was way back before COVID. So this condition can be seen in other infectious processes. How about myelitis? Spinal cord involvement. It can come as a band of sensation or in your tummy, or sometimes it's the leg, or you can have weakness. And this is a 53-year-old with myelitis. Look at the spinal cord below there. There's enlargement and there's enhancement. It's interesting, there's no disc disease. Usually when you take pictures, discs are always protruding everywhere. What about Guillain-Barré? Acute demyelinating inflammatory neuropathy. This has been touted as one of the complications of the vaccines. Usually in SARS itself, the Guillain-Barré presents just like any Guillain-Barré manifestation. It's an ascending paralysis. And you have variations like Miller-Fisher syndrome with cranial nerve involvement. The spinal fluid in Guillain-Barré usually shows high protein but no cells. This is not always the case in SARS. In SARS, the spinal fluid is negative most of the time by PCR for SARS virus. When you do the EMG, the usual manifestation of Guillain-Barré is a demyelinating pattern where you have prolonged distal latencies and conduction block. But you can also have axonal types, and you have fibrillations, absent of F waves, and so forth. The MRI may show nerve root enhancement. The prognosis is usually good. They respond to IVIG and plasmapheresis. I had a patient, a police officer, who came to us because he had SARS-CoV. He was seen by the occupational folks and disability folks. He was said that he can go back to work. Was never really diagnosed until he saw us. And as soon as we saw him, it was obvious that he had Guillain-Barré that was getting to be with him longer. And he responded to IVIG. And he started walking more with just one course. This is a 4-year-old with Guillain-Barré syndrome. This is the nerve roots enhancing. And this is the actual view of those. Picture is not as good as I would like. And this is a 36-year-old with Miller-Fisher variant. Miller-Fisher variant just affects the cranial nerves and to some degree the brainstem. So these patients have ophthalmoplegia, they have ataxia, and sometimes associated with the usual symptoms of Guillain-Barré. Sometimes they're unusual. And you can see here, the third cranial nerve is enhancing. And this is a coronal view of the left cranial nerve 3. This is an enhanced picture, What about other focal neuropathies? You can have a lot of them, but you have to be careful interpreting them if it's not the cranial nerve, particularly in the upper extremity, lower extremity. You can have critical illness neuropathy. The longer you're there, the metabolic abnormalities just affects the nerves. You can have peripheral nerve injuries, including positioning. So not all neuropathies are due to COVID directly, but maybe mechanical in nature. Muscles can be affected. You can have myalgia, and any muscle can be affected. You can have weakness. And you do the laboratory, there's an increase in CPK. Occasionally, there's severe rhabdomyolysis. And if you look at the MRI, there's myonecrosis. And you look at the histology, there's inflammatory infiltrates. They may respond to steroids. And this is an MRI of a patient myositis. The article did not say the age of the patient. And this MRI just tells you the upper part, involvement of the vastus medialis on the right side. And this is the obturator muscles enhancing. And when you do the contrast study, you can actually see the same muscles being involved. They do respond to steroids most of the time. Now, what about long COVID? As we call it, post-acute COVID syndrome, or PACS, PACS. That's the scientific name they want. Well, long COVID can occur after COVID, as expected. It's a post-acute manifestation. And this slide just tells you the course of COVID, week 1, week 2, week 3, and week 4. Usually by that time, patients start to recover, or you have more symptoms coming on. And from then on, you call it the post-acute COVID. Some even try to categorize it as subacute ongoing COVID-19 and chronic post-COVID-19. The longer you're from it, the more post-COVID it is, but the term they use is PACS, P-A-C-S. And as you can see, there's involvement of the multiple organs, heart, kidney, the lungs. We have patients with chronic cough that just doesn't want to go away. And whenever they talk to you, they just keep on coughing. If you look at CAT scans, they have the findings that are just persistent for a long period of time. There's involvement of the vasculature, the cardiovascular involvement. They always have palpitations whenever they move. Now, from a neurological standpoint, we look at now 3 patterns. Used to be we just had a lot of patients with multiple symptoms. We did not know how to look at them. There are 3 patterns that you can see. One is dysautonomia, one is exercise intolerance, one is neuropsychiatric. And I put multi-system inflammation syndrome in kids. As I said, it affects multiple organ systems, and it's associated with the peak of SARS-CoV, but they could never really say that that's the cause. In terms of dysautonomia, some patients have POTS, postural orthostatic tachycardia syndrome. They stand up, their heart rate goes up, and they feel lightheaded, they almost pass out. Hypotension and hypertension can go. It can go either way, high blood pressure, low blood pressure. There's gastroparesis. Some patients are constipated. Some patients have loose stools. They have cold extremities. There's peripheral vasoconstriction. A lot of them complain, I have a very low-grade fever all the time, and this could be a form of dysautonomia. Exercise intolerance, they're always tired. If they do activities, they have these 2 hours that they feel they're great, they work, they pay the price for 3 days. There's exercise intolerance. They have to marshal their energy. Neuropsychotic, they all come with brain fogs, short-term memory loss, distorted time, sleep disturbances, depression. I'm not sure if there's a 4th type, because a lot of these patients also have pain. They have myalgia, they have neuropathic pain, they have paresthesias, they have headaches, they have tinnitus. What's the pathogenesis? We do not know. We, of course, think it's inflammatory in nature, and perhaps it will just run its course. The treatment is multidisciplinary. You cannot separate the different organ systems. You got to look at the whole person. It's very intensive. And this slide just shows you the different practitioners that need to be involved. It's not one entity. It should be multiple specialties. In North Texas, I was trying to scrounge around where we can send patients with post-COVID syndrome. I know about UT Southwestern because I've sent enough patients there. They probably hate me by now. And John Peter Smith, but I don't know of any other areas. I don't know if Baylor has one, but I know that the rehabilitation of Baylor perhaps it's not, there's a lot of multidisciplinary neurological aspect, but I don't know if you can go in one place. Now, there's questions that come up with COVID-19, the SARS virus. Will COVID-19 lead to a better understanding of other similar but misunderstood conditions? For example, chronic fatigue syndrome, myalgia, encephalomyelitis is almost similar to long COVID. It's almost similar if you have COVID. One of my colleagues is a neurologist in town, very good doctor, told me I had COVID. Now I know what my fibromyalgia patients feel, and I only had it for 2 weeks. On the other hand, will COVID lead to future neurodegenerative conditions? If you remember, you probably don't know, everybody's young here, encephalitis lethargica has been associated with the flu and associated with Parkinsonism. Would 10, 15, 20 years from now, we'll end up with a whole bunch of neurodegenerative condition. If you remember, most of the neurodegenerative conditions have loss of smell, but that's probably a different pathology and different pathogenesis. Well, I'm going to end here and just state that COVID-19 has impacted us, not just medically, but in many other ways. And I hope we get through this soon.